It's 10 after. I know a lot of you are working and want to get back. So this is a very important, really interesting new program that's going to be starting here at Overlook. It's ERAS, and you're going to hear a lot about it. But it's something that's been going on in other places, and we're going to bring it to Overlook. Or they're bringing it to Overlook.
We're bringing it.
But it's really an important program, and it's such along the continuum. So it's pre-op, it's intra-op, it's post-op. So everybody is involved. And it's really important for everybody to know about it. So I would like to introduce Dr. Chin, the head of colorectal surgery here at Overlook, and Melissa Mohar Polly, who was one of our nurses on 6C and now works with anesthesia in the pre-op area. So it's going to be wonderful. Now, before we get started, wait a minute. Okay, we have to announce the disclosures because it's a contact hour program. Atlantic Health System is an approved provider of continuing nursing education by New Jersey State Nurses Association, an accredited approver by the American Nurses Credentialing Center, Commission on Accreditation. There's no commercial support for this program. Oh, wait a minute. Can you sign that I did that? The faculty and planning committee members have no affiliations with commercial interests to disclose and agree that this activity will be free of bias. Disclosure forms are required and reviewed for any issues. Accredited status does not imply endorsement by Atlantic Health System, NJSNA, or ANCC of any commercial product displayed in conjunction with this program. Successful completion of the nursing contact hour awarded requires participants to sign in, attend the entire program, complete an evaluation form. So certificates will be issued upon receipt of the completed evaluation. And with our shared governance, our professional practice model, as you can see, the little arrow is pointing to excellence in nursing and patient care delivery. Since this is an all-encompassing program, it's really important that this is going to help our patients and help our patient care. Okay, so without further ado, Dr. Chin will start telling you about the program.
Thank you, Marianne. We're really excited about this program, and as she was pointing out that this has been a process and evolution for well over a decade, and we're really excited to bring this opportunity here to Overlook. So part of the history is that in 2001, there were two professors who came across this idea at a London symposium, just talking about nutrition. And Ken Fioran was from Edinburgh, and Ali Lindqvist, I can never pronounce the Swedish names, was from Sweden. And they recognized that throughout not just the European continent, but throughout the world, there was a huge variation in management of certain disorders, particularly like colon cancers and surgery. And they felt that there were opportunities for improvement, and they subsequently developed an organization that in 2005, they developed the first evidence-based protocol for patients undergoing colorectal surgery. And that was actually published in a nutrition journal at that time. And as that evolved, they realized that there was something missing from it, that a simple protocol, a simple knowledge base or algorithms that we all have from school, nursing school, medical school, and all just weren't adequate, because there was more to a process than just following a certain schematic. So ERAS stands for Enhanced Recovery After Surgery, and there are studies that show that there are significant benefits to this without increasing morbidity. And one of the goals of ERAS is that it decreases length of stay. And we've looked at an organization at the University of Virginia that had 2 colorectal surgeons that was in an active practice. And what they found that over the course of a half year after implementing the ERAS, that the length of stays dropped significantly by over 2 days or almost 30%. And what that translated to was a benefit to all patients. Patients who had both open surgery as well as laparoscopic surgery. But there are other things other than length of stays that were important. One of the important things is patient satisfaction. And patient satisfaction improved significantly too. And the overall Prescani surveys had increased from their 26th percentile to the 59th percentile, just based solely upon the implementation of ERAS. The patient's sense of pain control, their pain management, jumped from 43th percentile to the 98th percentile. And when they discussed with patients how well were you prepared for discharge, they jumped from the 40th percentile to the 99th percentile. So patient satisfaction also improved with this as well. And the other thing is, as we know that healthcare does not operate in a vacuum, they found that in this system, basically through the implementation of ERAS, and every hospital will be different based upon the direct costs and other indirect costs involved, but they were able to save $7,000 a patient, or it translated to about $3,000 per day that the patient was in the hospital. And this is important because when you look at the number of operations that are done, for instance, at Overlook, we probably do close to 300 elective operations of the colon and even more emergent one. And if you extrapolate that out, there's a potential savings to the hospital that they can reinvest in future endeavors for patient care as well. But it also really is a reflection of how streamlining the process can really improve the system as a whole. Now, $3,000 is actually a little higher. I don't know if we have any of the business people here. I think most hospitals will say that they have an improvement from anywhere from $1,000 to $2,000. So they might have been a little more inefficient from the beginning, but certainly they're streamed down from this. So over the last decade, though, ERAS was almost like that mystical unicorn. We've heard about it. We thought we knew what it was, but no one here really ever saw one, because a lot of we've heard other hospitals were doing it, but I have to give credit to the anesthesia department, Melissa here. I saw Mary Pat here. I have to give her credit because she took the bull by the horns and helped us get funding and get appropriate administrative support to allow this process to go on. And with them and also the support staff of the perioperative services, we're excited that ERAS is really taking off now. We're going to be enrolling our first patient in the next couple of weeks. Now, I'm just going to give some overviews, and I'm going to get Melissa to do all the nuts and bolts and the heavy work with this. So how does it work? Well, part of the process, and I think this also goes to why patients have a greater sense of satisfaction, is it creates an informed patient. Okay, that's one of the goals, is that we're going to start informing the patient right from the doctor's office about what the goals are and what we plan to achieve. But the ERAS also results in decreased surgical stress to patients, and we're going to go through some of the measures that we think will be helpful in doing that. It allows patients to have an increased functional recovery, whether it's a decreased catabolic state from the surgery and the improvement of perioperative nutrition, as well as a decrease in the opioid use. And another thing that's going to be important for ERAS to function is we want to decrease variations in practices. As you all have probably figured out, most surgeons are pretty dogmatic and everyone has their own right way to do things. But there are a lot of correct ways to do things, but if we can decrease variations, it's better for the patient, it's better for the system, and patient outcomes tend to be better, and we have decreased morbidity with this. And I'll give it to Melissa. So how do we accomplish this? Probably the most important thing is a unified team approach. And this process, although Melissa, the anesthesia department, have really led the way here, has involved everyone from PATs to the intraoperative services to nutrition, to physical therapy, to the pharmacist. And through this, we think we're going to have a unified approach through the system. So when a patient comes into Overlook, they're going to get processed through in a seamless fashion here. The order sets that are going to be developed are going to be based upon high levels of evidence. So these are evidence-based practices that are established through the practice parameters of our National Society, American Society of Colorectal Surgeons. So every one of this will be level 1 and evidence, as well as some level 2, which shows the benefit, but there are mixed results on that. We've implemented the use of the preoperative education from the office, and we're happy to also add on the preoperative stoma cleanings to help us out with this, because in a lot of places that have stomas, there's about they have a lot of stoma patients. There's about a 15% readmission rate with these patients, and we think that we can minimize the morbidity associated with these patients as well. Decreasing the catabolic state starts preoperatively. So there was once a mindset, because patients want the cancer out yesterday, that sometimes it's better to take that extra week to build the nutrition up, to get them in a catabolic, to move them from a catabolic state to an anabolic state prior to surgery. And we've worked with nutrition on this, and Melissa will be going over all the processes that are involved, where these patients will be getting nutritional support after they come in for pre-admission testing. So they will hopefully come in anabolic instead of catabolic, and we'll follow this through with early feedings the night of surgery and carry that on to solid food, hopefully within 24 to 48 hours after surgery. One of the things that's critical in this is a process called goal-directed fluid therapy. And we've started doing this over the last couple of months, and it's raised a lot of eyebrows in the PACU and on the floor. And the feeling is that if a person has normal kidneys, they are better off having less fluid than more fluid. In the old days, in the OR, we were taught for every hour you're in surgery, you should have 1 liter of fluid. And when they get to PACU, they run at 100 to 125 mLs an hour. Well, now we don't think that's the best thing, because when the fluids get edematous, they don't function as well. The anastomosis swell, and they don't recover as quickly, so their ileus takes longer to resolve. So typically, if a person has normal kidney function, we generally run them on the drier side, and they may only get 2 liters of fluid, or 1.5 liters of even a 4-hour case. And one thing that's critical with that is the anesthesia's assessment. And I don't see Mary Pat here, but she worked through administration to ensure we got funding to get something that's going to be very special, is a non-invasive monitoring for volume status. So anesthesia will be getting a tool that they can measure cardiac outputs, stroke volumes, to ensure that the patient is euvolemic at the time of the surgery. So this way you're not guessing, are they dry, are they wet? Do you give them a bolus? And we're not going to get too much into fluid management, but something for the nurses on the floor is that we want them to get comfortable with this too, is that patients are going to be coming out of the OR. Many of them are going to be coming out with IVs of 40 mLs an hour, and not the 100 mLs. And if they look dry, instead of the reflex, give them a 500 or a liter of IVs, you give them only 250 mLs of fluid. And the concept of that is drier is better in these situations. And we're going to go over all that, and we're going to have more of a conversation opportunity after this. One of the big keys is multimodal analgesia. And the key is to avoid narcotic use. And initially it's going to be a shock. We're not going to use PCAs. So but when you add the multimodal analgesia, you tend not to need as much narcotics. And I think a lot of our nurses on the 7th floor have already recognized that some people don't even use it, because patients are coming out with gabapentin, they're on Tylenol, they are on Toradol or Celebrex, which are actually getting before surgery. And with these things, a lot of them, that extra Dilaudid, we just had a person on the floor, she got 1 dose of Dilaudid and it was just kind of like pushed over the edge. She was dizzy for a whole night, and She didn't want any more of it. But this is going to be a surprise. But when these patients go home, many of them don't even want narcotics when they go home. So the use of multimodal analgesia is very critical for these patients. And I think it avoids the narcotic use and potential addictions that we see in some patients. Other things are early folate removal. Right now, as you know, generally they're out within 48 hours, but the goal is in patients, typically those who don't have BPH or don't have diabetes or aren't having pelvic surgeries, many of them will come out the OR with their folate already out, or typically sometime on post-op day 0, that night after surgery. Early post-op mobilization, that's going to be a big factor too. That's kind of new to most places, most hospitals. I think the orthopedic surgeons have led the way on this, and we're going to be getting the patients out of bed within 8 hours of surgery. And that seems to be helpful with the patients. Early PO intake, again, we expect them to be started on cystic clears as long as they're nauseated after surgery. And something that's also really critical to this is the continued nutritional support after surgery. And as you know, we have the fellows that work with us, and they don't see it because, you know, once they don't see as much of the office follow-up as they should, or as we would like them. But what you don't realize is that most patients, once they're discharged, lose about 10% of the body weight. And so when they come back to the office, a lot of them will have lost 10 to 15 pounds already. And that has always been assumed to be obligatory, meaning there was nothing that we could do to change that. But I think with some of the immunonutritions and the nutritional support, our goal is to reduce that and allow a faster recovery with them. And a faster recovery with them, again, allows them to have a better functional outcome. And if these are cancer patients, they can restart their plan to cure sooner because they are soon able to take their chemotherapy. But so what is our potential here? And this is the last slide, is that in 2017, we did 280 elective cases. And the length of stay for the laparoscopic case was 4.2 days. The open cases were 5.9 days. In 2018, we saw a tick upwards for whatever reason. Okay, so we've seen the trend up like a half a day from the laparoscopic cases to 1 day. You know, we haven't drilled down on the data, but typically the case mixes over the whole year will be similar. So it's hard to say, but since we've been developing this ERAS process here at Overlook since May or so, and actually anesthesia has been doing it for 5 months, is that we've already implemented some of the things, and we've seen that the laparoscopic cases have come back down to 2.4 days. And this is critical because if you take this back, and these patients are actually anxious, or they are actually looking forward to going home early, as opposed to the concept, well, you're going to be here for 5 days, and also a lot of the education comes from us and laying down the expectations and keeping a unified theme through this process. Because if we can do this, it helps the patient, it helps our hospital in many ways, not even financially. It helps getting patients in, you avoid bottlenecks, you have more patient hospital days available. If you cut them in half, you open up half the surgical beds for more surgical beds and all. So I think there's a lot of opportunity here for us. I'm going to give Melissa the opportunity to tell us the whole process map. Pay attention, she goes through this very thoroughly. And we'll answer questions afterwards.
Yes. Good afternoon, everyone. Okay, so like Dr. Chin said, ERAS is a multimodal, multidisciplinary surgical pathway that minimizes the body's stress response to surgery. He did tell you about the founding fathers. It originally started with colorectal cases and now have expanded to other service lines such as GYN oncology, bariatrics, and total joints. Our neighboring hospitals such as Johns Hopkins, Sloan Kettering, Mass General, NYU all have an ERAS pathway in place. So there's about 20 or so core elements to an ERAS program, starting from pre-op all the way to post-op. I'm going to be talking about a few interventions in each stage. Dr. Already discussed the growing evidence that suggests ERAS contributes to increased patient outcomes, reduces post-op complications, and accelerates recovery. And again, a successful ERAS program includes a multidisciplinary team. Many departments, like Dr. Chin said, collaborated in this project: nursing alone, PAT, recovery room nurses, nurse management, nurse educators, NISQIC, case management, nurse educators, like I said, were all involved in this. Of course, the surgeons, administration, Dr. Audette and Mary Pat, anesthesiologists, CRNAs, nurse practitioners for the pain department, pharmacy, inpatient, as well as outpatient list pharmacy, and physical therapy. So let's take a walk through the surgical journey, starting with pre-op. This is our actual process map. It's our Bible to ERAS. And I really want you to focus more on the left side. I think you have handouts if you want to follow along. So 4 weeks prior to surgery, the patient will be educated in PAT about what the expectations are during the hospital stay. Screening for malnutrition will take place, an anesthesia consult where they'll be getting a prescription for pre-op pain medications to take the day of surgery. And that's going to include a Celebrex, a Tylenol generally, and a gabapentin. From there, that patient is going to walk over to their pharmacy of choice, or they can walk over to List Pharmacy in MAC Building 1. They can pick up their bowel prep, their anticoagulants, as well as their pain medications. Fluid and carbohydrate loading is a very important key element of an ERAS program. 1 week of nutritional shakes are to be given to the patient. They're going to take that 3 times a day. And then the night before, they're going to get a clear drink over here, 2 servings of that to drink the night before. And then 3 hours prior to post-op, they're going to have 1 more serving of carb loading drink. So no longer are the days of NPO after midnight. Before their surgery, they're going to see wound care for consults if they're a stoma patient. And then also it's important to know that our PAT nurses will follow up with the patients 1 to 2 weeks prior to surgery, again, just to reinforce teaching and increase compliance and answer any of their questions. So we're going to head over to the intraoperative phase, day of surgery. Day of surgery, it's a fine line, like Dr. Chin said. You don't want to overhydrate the patient. You don't want to underhydrate the patient as well. So we can measure this by using the Edwards monitor. It measures blood pressure inside the veins, heart, and arteries, and it really tells us how our stroke volume is. Again, reducing the use of surgical drains, NG tubes, and Foley catheters. We want that Foley catheter. The goal is removal prior to PACU. From an anesthesia perspective, give regional anesthesia such as tap blocks, lidocaine infusion drips, multimodal pain therapy, all to decrease the use of opioids. This slide is, I think it captures the multimodal pain therapy that anesthesia can use. Again, the use of NSAIDs, acetaminophen, gabapentin, our local anesthetics or tap blocks, as well as lidocaine, dexamethasone, and ketamine infusions. So post-op phase. Early oral nutrition, post-op day 0 starts on clear with clear supplements. We want that protein supply increased. It reduces starvation. Then if everything goes well by post-op day 1, we're tolerating the clears. And in the meantime, the patient is chewing gum to increase gut motility. Early mobilization out of bed and chair to the PACU. We're requiring all our patients to sit in the chair for all meals. And post-op day, 8 hours after post-op, we're going to ask them to walk 50 to 100 feet on the floor. Again, non-opioid oral analgesics, no PCAs, multimodal pain therapy, 24 hours of antiemetics to increase oral intake, promotion of protein, and increase mobility. And then upon discharge, Lovenox teaching, case management will definitely be involved. And then we're going to continue those shakes again for 3 more weeks. They're going to take that twice a day. And if you want a taste of it, VIA has some outside so you can tell your patients how you think of it. And then if eligible, wound care as an outpatient for 8 post-op visits. And then we'll see them, we'll call them about 2 weeks after a post-op, again, just to follow up and complete the circle. So that is a snapshot of our colorectal ERAS program.